Good morning. My name is Captain Baird from Nellis Air Force Base Family Medicine Residency. I am presenting a case report regarding a 26-year-old healthy male who presented with a case of scrotal and penile shingles from an S2-S3 nerve root. Sacral shingles is rare, only 4 to 8% of all shingles cases, and most of those are in immunocompromised patients. This case presents a diagnostic challenge in distinguishing herpes simplex virus, HSV, from herpes zoster virus, HZV, otherwise known as varicella zoster virus, VZV. The patient presented after a week of pain, itchiness, and rash on his scrotum and penis. He reported remote sexual activity of more than 6 months with no history of prior lesions. The patient was examined on day 7 of symptoms, and few clear fluid vesicles were seen. You can see the progression of symptoms between day 6 and day 10 from onset of symptoms in the patient's photos here. A presumed diagnosis of HSV was made and a PCR swab was obtained, but antivirals were not initiated. At our hospital, the HSV PCR swab also contains HZV PCR. About 4 to 5 days after presentation, results positive for HZV were obtained. The patient had had no new lesions for more than 5 days and was therefore outside the window for effective treatment. Sacral shingles is rare, and distinguishing HSV and HZV on clinical exam can be a challenge. This is an important distinction, particularly in immunocompromised patients, due to their increased risks of complications including dysuria, urinary retention, and constipation. HZV antiviral dosing is typically double that of HSV dosing. The presentation of a unilateral rash should increase suspicion for HZV. If practicing in a limited resource setting where PCR testing is not available, a zinc smear may be performed to aid in diagnosis. This test would not distinguish HSV from HZV and is not recommended for definitive diagnoses. Antiviral therapy should have been initiated in this patient with high suspicion of a viral etiology while awaiting his results. In conclusion, antiviral therapy within 72 hours of onset of symptoms decreases duration of symptoms by 2 to 3 days in both HSV and HZV. Therapy started outside this window, but within 24 hours of new onset lesions, such as this patient's case, is recommended and decreases duration of symptoms by 1 to 2 days. In the setting of a unilateral rash, strong consideration should be given for initiating the higher HZV dosing while awaiting test results. Finally, a zinc smear can be helpful in limited resource environments, but cannot distinguish between HSV and HZV. For those patients most at risk, distinguishing between these diagnoses and dosing therapy appropriately is necessary. Thank you.